Our presentation is on end-stage renal disease, and it will be presented by Ali Baltazar, Marina Gonzalez, and Jennifer Vargas. Mrs. Garrison is a 68-year-old female who came in with complaints of very dry and itchy skin that has increased over the last 2 weeks. They also have complaints of headaches and fatigue. They have a history of type 2 diabetes, which was diagnosed 8 years ago and has led to chronic kidney disease. They have a modified diabetic diet that is low in protein and is currently on diuretic medications. Their last GFR was taken 1 month ago and was 28. Their labs came back with the following: hemoglobin 3.8, platelets 100, B132, creatinine 3.8, sodium 131, potassium 3.7, glucose 166, and a GFR of 14. There was excess protein and glucose in the urinalysis, and they appeared very fatigued and disoriented throughout the assessment. After evaluation, the doctor diagnosed them with end-stage renal disease and ordered Epigen 100 units per kilogram sub-Q and Parasin 4 milligrams by mouth 3 times a day. The patient has also been ordered to start hemodialysis. However, they do not have an access port and are scheduled for placement of a vascular access device. Once the device is in place, they will receive dialysis in their hospital room. The doctor also mentioned that they made 1 unit of packed red blood cells due to the low hemoglobin level. However, the patient is Jehovah's Witness and may refuse the transfusion. So what is the pathophysiology of end-stage renal disease? Well, kidneys are one of the most fascinating organs of the body. Without at least one functioning kidney, the body would not be able to survive. Although science is always advancing, there is so far no way to have an artificial kidney. Kidneys are important as they remove the necessary waste and toxins from the body, along with regulating the necessary substances such as sodium, potassium, glucose, chloride, and water. The kidneys filter around 47 gallons of fluid a day in healthy individuals and also release necessary enzymes and hormones that regulate blood pressure, stimulate the production of red blood cells, and activate vitamin D so the body can absorb calcium and phosphorus, 2 minerals critical for bone health. Kidneys are so powerful that a person can lose up to 85% function before reaching end-stage renal disease and requiring dialysis. The CDC estimates that kidney disease affects roughly 6 million Americans, with 131,636 new cases reported annually in 2018. Care for end-stage renal disease costs the United States $35.9 billion annually. So how does someone develop end-stage renal disease? Well, it's the result of the advancement of chronic renal failure, which differs from acute renal failure in that the kidneys will never revert back to an increased glomerular filtration rate, or GFR, and will continue to decline over time. Chronic renal failure is established once kidney damage has been present for longer than 3 months and the GFR has decreased to less than 60 milliliters per minute. Usually it is the result of other chronic diseases such as hypertension, diabetes, glomerulonephritis, polycystic kidney disease, and neurotoxic exposure. End-stage renal disease is diagnosed once the GFR has reached less than 15 milliliters per minute. Normal GFR is greater than 89% and allows the body to get rid of toxins, waste, and excess water. Once end-stage renal disease has been reached, the only way to rid the body of toxic waste is through dialysis. Dialysis is an external filtration system that allows the blood to be filtered and returned from a machine. There are different types of dialysis, some of which will be presented during this presentation.
ESRD affects every body system, and this slide highlights just a few signs and symptoms associated with ESRD. Underlined are the signs and symptoms most commonly experienced in patients with ESRD according to the American Kidney Fund. Lethargy and generalized weakness are due to anemia associated with decreased production of erythropoietin in the kidneys, affecting RBC production. Anemia is also due to decreased RBC survival times due to uremic toxins and iron and folate deficiencies associated with dialysis losses. In the respiratory system, tachypnea, shortness of breath, and Kussmaul respirations are associated with acid-base imbalances due to the buildup of hydrogen ions that result in metabolic acidosis and subsequent respiratory issues. Oliguria and anuria are due to the inability of kidneys to produce urine. Anorexia is caused by the underlying chronic inflammatory processes present in CKD and dialyzed patients where signaling proteins known as cytokines interfere with the satiety center that result in a loss of appetite. Nausea and vomiting caused by the buildup of toxins in the blood, itching caused by mineral imbalances such as calcium and phosphorus, And lastly, muscle weaknesses and cramping, again caused by the buildup of toxins that result in muscle and nerve damage. So how is it diagnosed? Kidney function is classified into 5 stages according to glomerular filtrate per minute. That is, the amount of fluid or blood plasma that is filtered in the glomerular capsule for waste elimination is urine. GFR is calculated using a 24-hour urine collection to measure volume, creatinine, protein, hormones, glucose, minerals, and other chemical compounds during a 24-hour period. While the normal GFR varies according to literature, the average GFR in men hovers around 125 milliliters per minute and 105 milliliters per minute in women. It is important to remember that GFR decreases with every decade of life after 20 because of age-related physiological changes. To classify the degree of kidney function, GFR is used for staging purposes. From stage 1, which is characterized as being at risk, to stage 5, which is the most serious and final stage of CKD, is known as end-stage renal disease. It is characterized when the GFR reaches a filtration rate of less than 15 milliliters per minute. Alternatively, to determine the degree of structural damage, an albumin to creatinine ratio is calculated, with a finding of less than 30 milligrams per gram being normal and a finding greater than 300 milligrams per gram being an indication of ESRD and increased risk of mortality. The albumin to creatinine ratio is also determined through the collection of urine. ESRD is treated through a combination of drug therapy and hemodialysis. This slide will focus on the dialysis treatment as medications will be discussed at a later time. To substitute the function of the kidneys, blood filtration is done in one of 2 ways: hemodialysis or peritoneal dialysis, both of which operate using the process of diffusion through semi-permeable membranes. In hemodialysis, an external machine known as a dialyzer is connected to a vascular access device that was previously created in the patient. HD requires the patient to go in for treatment 3 days a week for about 3 to 4 hours each time. Though HD is the most popular dialysis method, geriatric considerations should be reviewed when discussing the best treatment plan, as fistulas often have a high rate of failure in older adults due to comorbidities, physiologic changes, and poor life expectancy. Common complications of HD include hypotension, disequilibrium syndrome, cardiac events, and reactions to dialyzers. In the second and less common method, peritoneal dialysis uses a catheter tubing that is connected to the membrane lining of the stomach, known as the peritoneum. PD requires a daily process, but because there are 6 different types, duration can vary from 4 to 8 hours a day to overnight or continuously, in which dialysis occurs 24 hours a day. The reason PD is a 7-day process and lasts much longer than hemodialysis is because filtration ability is far less due to the ultra-small capillaries in the abdominal lining. Common complications of PD include peritonitis, abdominal pain, and infections at the exit site.
End-stage renal disease can be treated with medications. First, loop diuretics are prescribed to remove excess fluid from the body. This helps alleviate fluid overload and hypertension. Next, parathyroid hormone modulators help decrease the production of parathyroid hormones by decreasing the gland's sensitivity to calcium. Also, this medication maintains blood calcium and phosphorus levels closer to normal. End-stage renal disease patients receive a variety of vitamins and minerals for treatment. Since they have dietary restrictions, lose vitamins and minerals during dialysis, and accumulate an excess of certain minerals. For example, vitamin D is given to help maintain healthy bones. Vitamin B and iron both help prevent anemia that is related to chronic kidney disease, and calcium helps decrease phosphate levels in the blood. Lastly, erythropoietin-stimulating agents are used to correct anemia. Medication instructions. Both iron and ESAs correct anemia in end-stage renal disease patients. Iron is a mineral that increases the production of red blood cells. Common side effects of iron include nausea, heartburn, anorexia, constipation, and diarrhea. The patient will need to understand that iron changes their stool to a dark color, and they should not worry. Next, ESAs correct anemia by stimulating the bone marrow to increase red blood cell production and maturation. Side effects consist of fever, diarrhea, nausea, edema, shortness of breath, headache, hypertension, and fatigue. Patients receiving ESAs will need routine lab work to monitor their hemoglobin levels to prevent overproduction of red blood cells, which can increase blood viscosity and the patient's risk of suffering a heart attack. Lastly, a phosphate binder such as calcium carbonate is prescribed to decrease phosphate levels. Side effects of calcium carbonate are a chalky taste, constipation, edema, hyperkalemia, and metabolic acidosis. Constipation tends to be the most common side effect in geriatric patients who take calcium carbonate. Patients can alleviate constipation by increasing their physical activity and taking fiber supplements or probiotics. Stool softeners and laxatives can be used, but should only be prescribed by a doctor since they can cause nephrotoxicity and electrolyte disturbances. Geriatric considerations. Geriatric patients are at increased risk for poor outcomes due to physiological changes of aging. As patients age, their healing times increase, they become more fragile, and they develop other medical conditions that have progressed, such as diabetes, heart failure, or arthritis. In addition to end-stage renal disease, geriatric patients have a higher rate of mortality. In addition, patients who undergo dialysis have travel restrictions since they have 3 to 4 scheduled dialysis sessions a week, and dialysis can be exhausting for patients. Geriatric patients are at a higher risk for hemodialysis complications like hemodynamic instability, depression, cognitive decline, malnutrition, and infections. Lastly, geriatric patients are less likely to participate in peritoneal dialysis due to impaired cognition, vision, and hand movements. Patient care with spiritual background and consideration. This slide will only discuss Jehovah's Witnesses. Jehovah's Witnesses are a group of individuals who adhere to the form of Christianity that Jesus taught and that his apostles practiced. According to Jehovah's Witnesses, followers do not accept blood transfusions because they believe the Old and New Testaments command them to abstain from blood, and God views blood as representing life. Jehovah's Witnesses do not accept whole blood, packed red blood cells, plasma, and autologous pre-donation. Acceptable products and procedures are renal dialysis, cardiopulmonary bypass, recombinant erythropoietin, and recombinant factor VIIa. When caring for a Jehovah's Witness, the nurse should always respect their beliefs and provide acceptable care and treatment.
That concludes our presentation, and these are our references on the next 2 slides.